Anybody would like to actually ask burning questions from either of the distinguished speakers? One question from Zezi Osman, virtual, to Dr. Rohisham, my boss. Salam. Assalamualaikum, Dr. Rohisham. How do you give NSAIDs at wound site and which NSAIDs?
Okay, thank you for the question. To be honest, I've never actually administered a local anesthetic to the cesarean section wound, but there are actually people who does that, and there are papers being published on NSAIDs infiltration at cesarean section wound. They have used diclofenac. They have used meloxicam. How they infiltrate, I'm not too sure, but I think one of the papers stated that it's run as an infusion over 1 or 2 days. But roughly for diclofenac, I think one paper stated that they use about 150 milligram per day. So macam just substitute the oral to do the infiltration. So roughly that's how they do it. But I think it is not necessary for us to adopt this technique, because I think the per-rectal and followed by oral diclofenac is just as good. And I think if it's it's working well for us, and I think we just continue what we are doing.
Yeah, I agree. If ain't broken, why change, right? But sometimes we have to go for the better. Okay, thank you, Dr. Rohisham. And next to Prof. Lee, the question from, I don't know from who. Oh, from the IT man, from Lacquer, the Ampang hospital managed to import. I thought only the football players, they import. Okay. Okay, from Dr. Amir, import player, Dr. Sani, manager, how much are you paying him? I don't get any payment, tapi Allah pahala. Amin. Dr. Amir Ayub, okay, actually it's a very good question. Should we push our O&G colleagues to develop the infrastructure to facilitate PMCD in out of OT area?
Out of OT area means still in hospital, right?
Yeah,
in the ED and all that.
Within
Yes,
the
I think
hospital.
so. I think so. I think they should. I'm not quite sure about KKM hospitals, but I think as far as HUKM is concerned, we do not have such infrastructure. While I was working, I don't know, maybe they will have improved by now. But I mean, these are the, I mean, if they actually arrest in hospital, the chances are actually better compared to out of hospital scenario. So it would be sayang lah to actually, have all these unnecessary delays and all that. Yeah.
Maybe I just add on to what Prof mentioned. I think we had to fight with the obstetricians. We had to educate them to perform PMCD. I think way back in 2007 or 8, where we have to actually present to them the papers about PMCD. But actually, Dr. Katz is actually an obstetrician, so but they're actually not aware that this we call algorithm is actually derived by him. When an obstetrician, it didn't come from us. So those days it was pretty hard to convince them, and eventually, but we managed to convince them. And I think over the years, the number of PMCDs being performed has actually increased. And I think HKL and definitely HSTAR, we have got a protocol on how to perform PMCDs outside the operation theatre. It normally doesn't happen in OT lah. Kalau datang ke OT memang nak perform Caesar pun. So it's labor room or ED. So we have cesarean section packs where we have all the necessary things in the pack. If the need arise, they can actually perform the PMCD where the patient collapse. Actually, another one thing I want to add on is what about if the patient rests in let's say a KK Botanic lah near Klang? Should we go over to KK and perform the PMCD, or should we bring the patient to HSTAR for the PMCD, or just leave it as it is because nobody is good enough to perform cesarean delivery at that center? I think there are papers saying that you should take the patient to where somebody can perform PMCD on that patient. So I think whichever is faster lah, whether you go over or bring patient to a center where it can be performed. A center that you have someone that can perform. In a clinic kesihatan, probably yeah.
Because I reckon, yeah, thank you, Dr. Rohisham. Also, Prof. Lee, I was just thinking for the PMCD to be done, I reckon it's a bit impossible to actually do it outside hospital territory. Why? Because Prof. Lee has just mentioned that the most senior obstetrician, OB-GYN, they have to do. Maybe in Klinik Kesihatan, there's no O&G at MO lah kot, I reckon. Kan? So it's a bit difficult. The one that I encountered in HKL, back then was in HKL before HTA, bukan HTA, Hospital Tunku Azizah, which is the Women and Children Hospital. Women and Children Hospital HKL, we did it in the ward, obstetric ward, early in the morning. So a bit difficult. But then again, we had to wait for the nurses to come up from OT and bring the whole trolley, apa tu, the scissor set tu. This is the purpose, right? You just need a scalpel and gallipot, that's all. But anyway, okay, next question again. The physical one, are you guys very happy? No question? Okay, I'm going to keep on the ball rolling. From Zazie Osman juga. Hi Prof. In Malaysia, what is the biggest deterring factor for PMCD?
Again, what's the question? Sorry.
Oh, okay, I'm just going to paraphrase it.
In
Okay?
Malaysia,
What is the biggest obstacle to performing PMCD? Itu sebenarnya soalan dia.
I think in Malaysia, it is basically the lack of knowledge and lack of experience. I think you know, those are the deterring factors lah. You've not heard about PMCD, or you know, and you've not done one before, so it is a very stressful situation in the first place. You know, half the time you're already, you know, trying to resuscitate, and you don't know how long the time has gone. You know, before you even want to embark upon a PMCD, it is something that one step that is difficult to take. It's just like last time we had, many years ago, we had somebody who actually had what appeared to be a pulmonary embolism. It's very difficult. You actually talk about internal cardiac massage, for example. Would you? Difficult. Yeah, we had somebody who actually had a cesarean section under GA for placenta previa type 4, recovered well, reverse extubated. Just as we were shifting her from the OT table to the trolley, she started complaining that she couldn't breathe, and she, you know, lost consciousness and she collapsed. We knew because the cardiac output, the tidal CO2 wasn't coming out, even though we had good compression and things like that, and you know, but we couldn't take the step to actually do internal cardiac massage. So she actually succumbed, and the postmortem actually showed that she had pulmonary embolism, sadly.
Yeah. Actually, yeah, it also came into my mind when I'm sure all of you have actually involved with the CPR, right? For not just for maternal, but for any patients, kan? Because start CPR, actually most of us will forget what time that we start, betul tak? Because everything we start in, everybody will be in panicking mode. So macam nobody remember to, okay, what time do we start? It's very chaotic. So maybe the take-home message to actually mark the time, the starting time of CPR, because usually after that, whether it's successful or not, then we're going to start document kan, pukul berapa tadi kita start CPR, dan agak-agak. So I think maybe just look at the time.
That is only good if it's a witness arrest. You know, time zero, the patient collapse, and then you start CPR. Sometimes you just find the patient, you know, in the collapse state.
Yes.
You really don't know when is the time zero, you know. You can only document when you started, but
Correct.
you don't really know when she collapsed.
Yeah, because most of the time, yes, as Prof. Lee said, unfortunately, I don't know, there's no statistic, but some of them are already collapsed before we attend to the patient. But whatever it is, what time we commence CPR, we didn't say that what time the patient loses consciousness. So that's one of the issues lah. Okay, okay, there you go. On the slide, Dr. Ani, my colleague ni, Dr. Tan Rui, is that you at the back kan? Seems like from the presentation, ED physicians other than obstetrician may perform the hysterotomy. Can the anesthetist overrule ED physician or / obstetrician and perform the hysterotomy instead of they think that it will improve resusc efforts? Prof. Lee.
Okay. I Personally, would not be as gung-ho as that, because even though I have got experience, personal experience in doing cesarean section many, many years ago, but there is an obstetrician. If you actually have an obstetric colleague and all that, by right, they should take the lead. You can, I suppose you can persuade him and all that, but short of taking the scalpel yourself, I really don't know whether, I know we all try to do our best for the interest of in the interest of the patient and all that, but I don't know whether that would overstep the boundary or not, seriously. If the obstetrician is not present, I think we should take the lead. Yeah. So this thing about, the question is whether you can overrule, isn't it? If the obstetrician is that, it's actually basically his domain. It's just that they don't tell us how to intubate patients, right? Okay. Right, Dr. Rohisham?
It's a very delicate issue lah, kan, sebenarnya. So we just have to play by the rules. Okay, and then next is a question from my colleague from HKL, I guess, Kwok Fan Yin. Okay, from HKL, for Malaysian data, were all PMCD done within 4 minutes of arrest? Hi, Prof, from Kwok Fan Yin.
Hi, Fan Yin. We spoke yesterday. Okay. This one actually basically you should refer to Dr. Rohisham, because he was the one who actually, did the chapter on PMCD, in the 2012-2014 report for CEMD Malaysia. But from what I can gather from his chapter is that we don't really have sufficient data to, to say whether it's been done. I shown in my slides, which I just glossed over, those infants that survived. I think one was, delivered within 4 minutes, but the rest were not. So I assume that the PMCD was not done within 4 minutes.
Dr. Kwok, I just add on to what Prof has mentioned. Actually, the data, like Prof mentioned, was very scarce, and most of the PMCDs done, we don't really have an exact timing of delivery. So that's number one. Number two, actually, we only see from my chapter, we only seeing the dead mothers lah. So I assume, of course, I think there are some successful resuscitation being performed, and where the mother actually came out alive. So again, we don't have that registry as yet. So maybe something we need to think about in the future.
Well, that's prevalent not only in Malaysia, but in all over the world. We don't really get enough data about this one. Like I said, if you actually look at mortality studies, basically the registry is on those who didn't make it. We actually don't have, morbidity studies, large-scale morbidity studies as well. The one that I quoted to you earlier on, the UCOS, they just do, sampling like that, just one-off studies and not a continuous registry, unfortunately.
Yeah, it's true. So I think maybe because of the incidence is a bit low, I reckon.
No, actually, walaupun low, if you look at our deliveries, we actually have got a very, very high deliveries in our hospital. We're like a factory, if compared to a tertiary hospital even in UK or Australia, their deliveries are actually 3,000 or 4,000, nothing like us, So we are 3 or 4 times higher producer of babies than even the developed countries. So I think with regards to the protocols, how to perform PMCD, you must have a proper one. So that people don't have to think who to ask, kena tanya boss dulu buat ke tidak. By the time it's gone lah, precious time has gone. And I think we are still seeing until today people are doing CPR sampai 1 jam, 2 jam, PMCD still not being performed. So I think if you don't perform, you just stop at 1 hour lah, don't have to proceed lah. But you will get question from me lah, kenapa tak buat-buat? Because I go through all the maternal death lah in the country. Okay.
I think memang for CPR, for maternal one, it's a bit sentimental, right? We try to prolong because nobody dare to say, okay, time out, finish, kan? So compared to the non-maternal resuscitation. Okay, thank you, Prof. and Dr. Rohisham from Kwok Fan Yin. So Dr. Kwok, prepare, boss is coming in next month. Any other questions from physical, or you want to actually type inside into this also okay juga? Any other lagi? Okay, Zezi lagi. Oh, Zezi. Hi, Prof. You mentioned that in a case where the mother is refusing PMCD, if it unfortunately happened, do we comply with it even though she is sound, mentally sound, when the decision is made? Dilemma, Prof.
Zazie, why are you giving me difficult questions? Yeah. Okay. In a less extreme case, can I ask you back the same question? Let's say if a mother antenatal checkup, she says no epidural for me whatsoever. Don't do epidural for me. And the obstetrician is stupid enough to put it in the case note. Patient requests no epidural, and in labor she's in severe pain. Whatever antenox ke, IM petidin ke, semua tak jalan. And then she said, please, please, please give me epidural. And you say, mark the case note, you see that sentence, no epidural. What are you going to do? I think it's probably easier for us to discuss this rather than a PMCD. It's the same principle anyway. Zazie, what would you do?
Zeti is not here to defend herself. Tapi I think Prof, the epidural I think is more of a luxury. It's a not dire emergency situation, right?
Yeah, I had problem with that. It happened to me, caught me out a few times. Of course, the first thing I do is to scold the obstetrician. Don't put down these things in the case note. You susah menyusahkan saja. Okay. Secondly, I would talk to the patient and say that I mean, if she really want to change this one, she will have to actually, write it in the case note and countersign it. Obviously, this is not in the PMCD situation. Right. Let's say if, again, it is a very theoretical kind of thing. I don't think antenatally the mother is going to say, if I suffer cardiac arrest, don't do the PMCD. So it's very, very theoretical. But I think to save her life and to hopefully save the fetus, I'm going to perform the PMCD.
So
that's my personal opinion.
Against her will.
Yeah. Maybe,
Interesting.
okay, the other thing would be some mothers actually refuse cesarean section even though the baby is having fetal distress. That's probably more common. That's another argument lah. Dr. Rohisham?
I'm gonna err on the mother side. Like if they actually documented that they refuse PMCD, I probably will not perform. But I don't think this will occur in our country as yet. I don't think any of the mothers are actually educated about this whole affair, unless they have got concurrent medical problems. For example, if maybe they have got a primary pulmonary hypertension or severe VSD with Eisenmenger, and they anticipate that they may collapse during delivery. So probably this sort of mothers will actually decide on not having resuscitation at all started on them.
This one considering if SA1 not with Eisenmenger or that. Okay, so I've just given instruction to actually wrap this. Okay. Diana.
Hi, Dr. Azizan. Yeah, I'm a specialist from Hospital Wilayah. I'm here in the capacity of specialist from Wilayah and also a wife of a. I want to share my experience, especially want to respond to Amir's question. I'm lucky in a hospital with an obstetric anesthetist.
Dr. Noliza.
Dr. Noliza, we do have a protocol for PMCD, even a set of CSSD was is in the ED 24 hours. So we don't have any deterrences from the part of ED physician or O&G or even our part. At the time of 4 minutes or 5 minutes, PMCD is usually being considered as one of the options to enhance survival of the mother lah. I myself experienced once, but sadly my patient did not survive. Okay, thank you.
Thank you, Dr. Diana. Yeah, so I mean, when we do PMC, doesn't mean that the outcome will be good, but at least we have given our effort. That's the main thing, and let Allah or God decides later. But talking about the set, if I'm not mistaken, HTA pun, not HTA, sorry, HTA. I think they were preparing a set last time, just a simple PMCD set, which will be put in the labor room or CAC or PAC, whatever you call it, admission center. If I'm not mistaken, before I left to Putrajaya. Okay, so sometimes I just realized that this is the end of for the session, but if you still have burning questions, you can actually send via virtual and it will be answered individually by the distinguished speakers. I just realized that both of them were examiners. I'm sure there are some of you might have gone through them for the final exam. But now I'm the examiner, throwing questions to you all. Tapi I think they did very marvelously. So please join me in thanking both speakers, Dr. Haji Muhammad Rohisham bin Zainal Abidin and Professor Dr. Lee Choon, the ever young looking. Okay, with that, please join on behalf of Dr. Rohisham, Obstetric Anaesthesia. He's the convener for the subspecialty in Obstetric Anaesthesia. Please join. We still need more people, especially the guys. And with that, I wrap up our symposium on obstetric anesthesia track. Thank you to the organizing committee headed by Dr. Sani for the marvelous course. It reminds me of MSA actually, MSA College Annual Scientific Congress, which should be held next year, early August. You'll see my face again. Okay, with that, I'll sign out. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Thank you.